Hello, my name is Matt Bott. I'm a thoracic surgeon at Sloan-Kettering. I was asked to speak in this short lecture, which is essentially a abbreviated version of a webinar that we had put together a while back in regard to multidisciplinary treatment of patients with lung cancer. And I'm speaking specifically about the surgeon's role in the multidisciplinary care team. So, accurate diagnosis and staging is really critical for patients with lung cancer. And this is a space, I think, where surgeons really can play a major role. It's essentially shared with other disciplines like interventional pulmonology, but as I'll show you in a second, in my opinion, surgeons really have a lot of value here. And just underscoring the importance of staging, these are expert consensus statements from the AATS that we had put together a little while ago, really reinforcing the idea that accurate diagnosis and staging really is critical to select appropriate treatment for patients, particularly in regard to neoadjuvant therapy. So I mentioned that this space is occupied by several different disciplines, but in my mind, you could really think of surgeons as sort of a potentially central provider in all of that. Right now, in the era of robotic bronchoscopy and endobronchial ultrasound, we really have the ability to diagnose, stage, and potentially even treat patients all within one procedure if you really felt inclined to do that. The other thing I think that's important with surgeons as sort of diagnosticians, if you will, is molecular testing, right? And we'll talk about that several times throughout the talk, but doing good biopsies to provide adequate material for both histology and molecular testing as well as staging. I think these are all things that surgeons can do quite well. So as you probably know at this point, in the setting of early stage disease, surgeons can be potentially the sole provider, but in the situation of more locally advanced tumors, this can get quite complicated, particularly in regard to systemic therapy. And this is sort of an overview of systemic therapy options over the past 20 years or so, and you can see that it's grown increasingly complicated, and in particular now, in the era of chemoimmunotherapy for patients with locally advanced disease, surgical input in those discussions, I think, is really important. And typically, I think within for those patients with locally advanced disease, they tend to be treated in a multidisciplinary fashion. There's a medical oncologist, surgeon, sometimes a pulmonologist, or even radiation oncologist. And really that care, I think, is best administered within the context of a multidisciplinary team, a more sort of formalized structure for treating those patients. And I just wanted to point out here that there is data in the literature suggesting that for patients with lung cancer specifically, that those that get treated within the context of an MDT really do actually have improved outcomes. I think something for all of us to think about and actively participate in. So there are a number of members of the team, and I think things that and data points that sort of go into the decision making. And again, many of these I think are actually generated by surgeons. So obviously, there are surgeons on the team, medical oncologists, radiation oncologists, pathology input is important. Other disciplines, physical therapy, nursing, pharmacy, radiology, pulmonology, all these folks I think are add a lot of value and are stakeholders in choosing the optimal treatment for patients. And some of the data points I think that are important there are things like size of the tumor, the potential structures, surrounding structures that it invades, nodal involvement. Are there any potentially metastatic sites? And then for surgeons in particular, what extent of resection is necessary? The team could also potentially review patient factors, age, performance status, comorbidities, respiratory function, and in the context of surgery, this all serves to sort of estimate the patient's risk of perioperative or postoperative complications. And then, as I mentioned earlier, I think in this day and age, histology and biomarker analysis really is critical, and that could be, basic histology, or more likely these days, mutational status, PD-L1 expression, and maybe even in some cases circulating tumor DNA. So I think one of the main services that surgeons can provide within the MDT would be evaluating the operability of patients, and that can be either medical or technical, right? And I think it's important to point out that there is some component of subjectivity in that assessment. You may ask a number of surgeons whether a surgery is feasible or recommended in a given situation. You may get different answers depending on who you talk to. There's no necessarily clear-cut guidelines all the time, but it's an important concept because if you look at the clinical trial data, about 20% of patients in the chemoimmunotherapy studies don't proceed to surgery after their preoperative treatment. So clearly, surgeon input from the beginning, I think, is important, and maybe it's imperfect. Maybe that's at least in part what that trial data says. But it's worth thinking on our part about ways to improve that. And for surgeons, it's also helpful to listen to other members of the DMT because, if patients are ultimately non-surgical candidates, then maybe those folks can inform what alternative strategies might be available. I included this slide because this is data in patients that are sort of borderline resectable, but within the context of an MDT, were selected for an approach that included surgery, right? So these are, I think, situations where the input from the team is particularly valuable, and again, surgical input is really critical. So this is a study that we were part of, published earlier this year, that looked at just over 100 patients with borderline resectable stage 3 lung cancer. Most of these were stage 3 based on either their T status or the involvement of mediastinal lymph nodes. And again, in this population that was selected for a potentially perioperative and surgical approach, 75% of those patients did actually proceed to surgery, with 96% obtaining a complete resection. So I think, sort of evidence to the fact that oftentimes these MDT discussions do actually work in terms of really selecting optimal treatment for patients. One of the things that was noted is that higher response to the preoperative chemoimmunotherapy did actually predict patients going to surgery. So again, things to figure into the DMT discussion as far as, will the patient be operable at the end of treatment? Well, what's their likelihood of responding to therapy? And input from medical oncology, but also from pathology, is really important. So the clinical pathologic factors that came out in that study, were things like mutational status, KRAS, STK11, KEAP1, PD-L1%, tumor mutation burden. Again, so all the disciplines really contributing to try and select patients for the best treatment for them. So I'll summarize the talk just saying that I think staging and in regard to surgeons within the MDT, I think staging and diagnosis, including lymph node evaluation and these days molecular diagnostics, are really critical in order to select optimal treatment for patients with at least potentially resectable lung cancer. Surgeons really are a very important part of the preoperative pathway, and have to be active, sort of vocal members, I think, of the multidisciplinary team, and really need to be familiar with diagnostic technology, as well as multidisciplinary treatment paradigms, right? We need to know these days about preoperative therapy, chemotherapy, immunotherapy, targeted therapy. All those things really factor into the care of our patients. And to that effect, multimodality therapy really has evolved quite rapidly, and probably will continue to do so, over the course of the next 5 years or so, I would imagine. And then multidisciplinary teams, within the context of that complexity, multidisciplinary teams really are critical for trying to tailor treatment approaches to individual patients and in the process, providing optimal outcomes. So with that, I'll say thank you for your attention.